but just so it's not too loud while Julie's trying to speak and it's not distracting. Also, Julie, I was wondering, for those of you that don't know you, I mean, obviously you're the owner of Fundamentals Physio, Fundamental Physio. It's really early in the morning apparently, but that's okay. But I want you to actually share, if you're comfortable with it, a little bit about your story specific to this topic, because I know you became really passionate about talking about pelvic floor health because of your own experience. So if you're cool sharing a little bit about that, I think that'd be a really cool intro for you, but also a way to warm everyone up for the whole topic.
So welcome guys, thank you. Once again, for those just joining us, if you want me to see you, just tap the bottom of your screen, red video camera, it's gonna say start video. So I'm Julie. I am physiotherapist and owner to Fundamentals Physiotherapy and Wellness Clinic in Oshawa, Ontario. So I became passionate about pelvic health a couple of years ago after having kids. Some of you guys may have had kids, some of you guys may not have, but I had a couple of issues postpartum. After my first baby, I had a lot of pelvic pain. Specifically with the intercourse. So I saw a pelvic physio for that. And then after my second child, I had a really kind of emotional experience. And I'm just gonna share that with you so that you guys know that what happens and what is happening to you is okay. It's okay to talk about it, and you don't have to feel alone. So about a year after I had my second child, Mila, my mom was visiting from the East Coast. We were playing in the kitchen. I was carrying Mila in a carrier, and I'm a physio, so I know how to wear her properly. She's like, I can kiss her forehead, but my oldest daughter felt very left out. So I said to her, why don't we just piggyback, and then I can carry Mila on the front, Aria, you can come on the back. So I squatted down, and she put her hands on my shoulders, and I stood up. And all I felt was like a drop or like a thud in my vagina. And I looked at my mom and I just started crying. It wasn't painful. It was just the weirdest sensation that I had ever felt. And my mom looked at me and she's like, what's wrong? Like, what's wrong? And I'm like, I don't know. I was like, I feel like I have a ball in my vagina. And I can laugh about it now because it's okay to talk about it. And I took my phone, I Googled it. I was like, I think I have a prolapse. My mom's like, what's a prolapse? So I tried to explain it to her. That night I called my OB. I booked an appointment for the next day. I went in to see him, and he did an internal exam, and he was like, no, you're okay. You're fine. There's nothing wrong. And I looked at him, I'm like, are you sure? And he said, yeah, it's fine. So I left his office bawling and crying because I said to my mom, like, I'm not okay. I am walking and I feel as if there's a baseball in my vagina. And no, it's a really hard concept to understand if you haven't experienced it, but there's a huge percentage of the population that has that. I suffered from stress incontinence, so like a lot of you guys probably experience as well after having babies, like the little bit of leakage with coughing, sneezing, jumping, or any sort of running activity. I have a mild diastasis, but the prolapse is basically my experience. So from there on out, when he told me nothing was wrong, I promised myself that I would be that person who's going to advocate for women to say that it's okay to talk about this stuff. And if you're experiencing it, that to realize and to know that you can actually get help. So that is my story. Is a little crazy, but at least you guys know that you're not alone in a lot of the symptoms that you do feel, or if you're here as a preventative approach, that's okay too. So
Amazing. Thank you so much for sharing that. And I know a lot of people are probably not going to share their story. We can't have everyone share their story anyways, but I feel like a lot of people could relate to that on one level or another. And I think it's cool that you have a story that made you so passionate about this. So thank you. Before you get started into your whole thing, I just want to ask that everyone, if you have a question, just so Julie doesn't get distracted, please put it in the message box and we can either do it at the end, or if I think it's really relevant to what you're talking about at that moment, I will just interrupt. I will unmute myself and then I'll ask Julie to answer that now. But otherwise, we'll have discussion at the end as much as we can. Alrighty.
So I don't know if you guys realize that pelvic health concerns, they're my mom, they're much more common than we realize. When we look at the stats, 1 in 4 women have incontinence. And don't get me wrong, there's different types of incontinence. There's stress, there's urge, there's like an overactive bladder, there's a lot of different issues like that. But 1 in 4 of us, so if you look at your screen, 1 in 4 of us suffer from incontinence, which is why we're here. And usually the percentage, like from the age of 20 up to 50, it can range from 20 to 40% of us, which is crazy. And technically 3.3 million suffer from incontinence. If you look at an overall picture, it's not just women, it's men, it's children. So it does actually affect the population to a large extent, not just us. I'm not sure if any of your kids have issues with respect to either incontinence or constipation. They're all considered pelvic health issues. But what the stats that I think is crazy is only 1 in 12 people will actually seek treatment. So Ash, how many people are on the call right now, roughly?
47.
47. So, oh my gosh, who's good at math? So 4?
I can do this.
So I think it would be 4, right? 4 to 47?
47 divided by what?
12. 4. So only 4 of us would.
Yeah, 3.9, so 4.
That's why I'm a physio and I'm not a mathematician. So only 4 of us will actually seek treatment for the symptoms that we're having. Who thinks that's crazy? But how many of us know that we actually can have treatment too? Yeah. So what I want to talk to you guys today, I kind of want to, if anybody has any questions about any certain conditions, I really want you to reach out and make sure that you post that in the chat. But my first goal is to teach you kind of about how your pelvis works, how the pelvic floor works, how your breathing works, and why we actually have these types of conditions. I'm assuming that a majority of the people here are probably here because of a stress incontinence, which is your leakage with coughing, sneezing, jumping, that sort of thing, picking up your kids. If you guys are comfortable, can anybody raise their hand who actually suffers from a stress incontinence? Yeah. Does anybody have like an urge incontinence, which like, and you may not even actually end up leaking, but does anybody feel like they have to go to the bathroom quite often? Yeah. Who here, when you leave the house, you always go to the bathroom before you leave? Oh yeah, big time. Do you know that that's become a habit? And it's actually not good for your bladder? And we'll talk about this after. So there's a lot of cool stuff when it comes to pelvic health. Who wants to see the muscles in the pelvis? There's a lot of muscles down there, and there's a lot of tiny muscles. So the first thing that I'm going to teach you guys today, because if you understand how your pelvis works, you're going to understand why these things happen. Okay? So a stress incontinence is usually leakage of our blood from, obviously, urine from the bladder. Now, this is our pelvic floor. So how I describe it to patients is your pelvic floor is a sling, okay? So if you think of your hips, your pelvic floor actually acts like a hammock. So all the muscles underneath basically support all of our organs. Okay? So when we breathe in, everybody knows what their diaphragm is? Yeah? So when you breathe in, your diaphragm pushes down. Okay? So when you take a big deep breath in, your belly goes out because your diaphragm goes down. What do you think happens to the pelvic floor when you take a big deep breath? It drops. Yeah. So it's supposed to relax. So if you think of a balloon, right? So when I'm breathing in my pelvic floor, this is pushing down against your pelvic floor. Okay? And when you exhale, so when you breathe out, the balloon lifts up, which is your air in your lungs and your diaphragm, and the pelvic floor lifts up. So when you guys work out, what do you think happens if you hold your breath? Do you think it's good or bad on your pelvic floor? Exactly, exactly. So if you have all of your breath pushing down against your pelvic floor, and your pelvic floor is pushing up, trying to hold all the organs, you're putting your pelvic floor in a really mechanically bad position. So a lot of people with a stress incontinence have a weakness in their pelvic floor, or they have an uncoordinated breath. Okay? And people say, well, what does the weakness in the pelvic floor have to do with me leaking? When you look at your pelvic floor, okay? So basically what's happening here is this is our rectum, this is our vaginal hole. I'm totally okay talking about this stuff, you guys know that. So you see these little muscles that run around the vaginal hole? And then you see this muscle that runs around the rectal hole as well as our vaginal hole? If they're strong, they contract and they close the hole. Okay? If they're not strong enough, the hole only closes a little bit. So when you're doing jumping or sneezing, and all that pressure is pushing down and you can't close the hole, what happens? You leak. Yes, yes. So if the pressure is too much and you're weak, you get the leakage. Does that make sense to everybody? Right? But sometimes people aren't very weak. It's just that there's so much pressure pushing down on that pelvic floor that it just can't handle it. Okay? So with stress incontinence, our goal is to teach how to contract those muscles. Who knows what a Kegel is? Yeah. Okay. Do you guys know that half of the patients that I see with pelvic health issues, whether it's in the clinic or virtually, that they actually bear down instead of pulling up? So as if like you're pooping instead of stopping your urine flow. So a Kegel is if let's say you had a little raisin at your vaginal hole that you're trying to pull that raisin up, or if you're urinating that you're trying to stop the urine flow. So it's that contraction, right? So we're trying to pull up. So a lot of the people that I see actually bear down as if they are having a bowel movement instead of pulling up. So that's why teaching people how to do a Kegel. So I can tell all of you to do a Kegel. I would guarantee you that there would be at least 10 or 15 people that actually would do it improperly. Crazy, eh? And they say, oh, well, I think I'm doing it right. And I'm like, it's actually, you're doing the opposite. So you're making it worse. So Kegel training and assessing patients or having them assess themselves, which we can do virtually, is really, really, really important, because I can tell you to do Kegels 3 times a day, but if you're not doing it properly, it's not going to be effective. Does that make sense? Right? So we said, who here said that they suffer from the stress incontinence? Yeah, and some people have urges as well, right? So that's basically why stress incontinence can happen. It has a lot to do with kind of your coordination of your breathing and your diaphragm pushing down and the pressure on the pelvis and the weakness in that pelvic floor that they can't get that full closure. Does anybody have any questions about that aspect? If you do, raise your hand. No? Pretty straightforward, pretty simple when you're able to kind of see how that happens, right? And we're going to do a couple little things at the end of the call too that we can kind of assess you guys how you're moving. So that's the basis to stress incontinence. Okay. Now, who here knows what diastasis is? Diastasis recti, separation of the abdominals. Anybody have it? Anybody ever been assessed to have it? So another thing that happens with pregnancy and having babies is a diastasis recti. And I'm sure a lot of you guys have it and may not even realize it, but it's basically separation of the abdominal wall. So when you do a sit-up, does anybody ever see bulging in through their abdominal region and ever wonder why? No? So basically that has the same thing to do with coordination of their breath, that there's so much intra-abdominal pressure from that breath. And if you think of your abdominal walls, everybody know where that 6-pack is, right? It's the separation, and then you get the air and the bulging of the organs through the abdominal wall. Okay? So diastasis, if anybody has a question about that, feel free to mention it as well. So does anybody have, so there's diastasis that we see commonly, stress incontinence, and then there's also pain with intercourse. Now I know this is a fairly touchy subject. Anybody ever have pain with intercourse? Does anybody know why? Now there can be a lot of issues with intercourse, and it can be, you know, you can have pain on penetration, you can have pain internally. So there's a lot of different types of issues. If your skin is very sensitive on the exterior, near the vulva, near the clitoris, near the labia majora, which is basically all that frontal exterior tissue. If you have sensitivities there, we usually call that's kind of a different condition, because that's more of your actual soft tissue. And then if you have pain on penetration, that is usually either trigger points or it can be tightness in your pelvic floor. So do you remember how everybody tells you if you have pelvic floor issues to do Kegels? If you have trigger points, which means really sensitive, really tight muscles in your pelvic floor, do you think Kegels would be good for you? No, because the tightening of the Kegel, of all of these muscles will increase your symptoms. So somebody who's suffering from internal discomfort or pain with intercourse, you're going to respond better to soft tissue techniques, like release with dilators or pelvic wands, to kind of desensitize all of those areas. Okay? So pelvic health, it's a very general, it's kind of like an umbrella term, right? So I can't tell everybody to do Kegels because Kegels might not be right for you. So if you're suffering from stress incontinence, we have to determine, okay, is it because of uncoordinated breathing, which we'll go over after, Or is it because of, weakness in your pelvic floor? Or is your pelvic floor muscles already really, really tight that they just can't contract because they're already sensitive and tight? And if you have pain with intercourse, it's tightness, it's sensitivity of all those internal structures. Okay? And there's some things that I'll show you guys after that if you do have pain with intercourse, there's tools that you can use to try and release some of those tissues. But like I said, pelvic health is an umbrella term. So it's really hard to say, you need to do this, you need to do this, you need to do this, because every case is different.
Hey, Julie.
Yeah.
I just want to ask you a question in case it's relevant at this point. So some people are saying it's not necessarily pain during sex, but they get a lot of pain when they're ovulating. And it feels like they're wondering if that's connected to pelvic health, and they feel like they're almost like having another child again.
Well, it could be a variety of things. There's, polycystic ovarian syndrome, which can sometimes cause pain during that period. There's endometriosis. So there's a lot of different conditions that can increase symptoms during ovulation time, or it just might be actually that you have increased symptoms because of everything shedding and the ovulation factor. But PCOS and endometriosis are common conditions that people have, which have an increased sensitivity during ovulation time. Does anybody have a diagnosis of endometriosis or PCOS? If you do, can you raise your hand? Yeah. Does anybody know what that is or what they are? Jen does, yeah. So PCOS is basically, it's a condition where there's extra hormone imbalance in your system, and it's usually androgen. So you tend to have a change in your ovulation function. You can develop cysts on your ovaries, and it can be quite painful. And for those of you that have it, I'm assuming that you do typically have that. And then endometriosis. Anybody have endometriosis? Yeah. So that is, that's usually like a shed, when you ovulate and when you have shedding of your lining. You also have that kind of happening outside of the uterus. So there can be a lot of scarring of tissue that can be really painful as well. So usually, Ash, that's when we see extra kind of more symptoms around that ovulation, if it's PCOS, endometriosis. Yeah. So somebody was asking about using tools for treatment. You 100% would want to be assessed by either, an OB or a pelvic therapist to whether or not you should be using any tools, that sort of thing, because you have to determine exactly what your symptoms are and what's contributing to your symptoms. If you don't have any trigger points, you wouldn't be using a pelvic wand or a dilator to kind of release those trigger points. So like I said, when we're doing a webinar or like a workshop like this, everybody is very unique. So the key is finding out your contributing factors. I'm just educating you on the different types of conditions that can happen and the aspects that contribute. A therapist would be somebody that you would talk to, discuss your symptoms, and then they, alongside of you, would be able to determine your contributing factors to why you are having the symptoms that you are. Does that make sense to everybody? Yeah. Because, and everybody's different. Like, I don't want to say, okay, you're having breathing issues, you're not having breathing, like everybody is very unique, and somebody who has to work on their posture to maximize their breathing might be different from somebody else. So Victoria may be different from Michelle, and Michelle may be different from Jen. So it's all kind of a unique case. So I'm going to, before we kind of answer questions and things like that later, I'm going to show you guys basically how breathing works. And I know a couple of you were talking about having like an urge to go to the bathroom and having frequency of having to go to the bathroom. So I kind of want to explain to you guys why and what happens kind of with your leakage and with your bladder. So I love whiteboards. Love whiteboards. So for those people who feel like they sometimes need to go all the time, okay, this is what we're basically going to talk about right now. Your bladder can hold about 400 to 500 mils of urine. I don't know if you guys can see that. Okay. We have signals that go from our brain, our bladder, to our brain to tell us when we need to go to the bathroom. Okay. We have this little tiny signal at 100 mils. Okay. Usually we just keep on going about our day and we forget, we just kind of miss that signal because it's just telling you that your bladder is starting to fill, but it's not full. Okay. When it hits 400 to 500, this is when we usually head to the bathroom. A lot of women that I see in the clinic say that they're going every 2 or 3 hours and they go every time before they leave the house, whether it's to the store or to go for a walk. Okay. What's happened is you are starting to go to the bathroom when your brain gets that little tiny signal that we usually are supposed to forget about. Okay. So if you go at this signal, what's going to happen is you are going to, I'm going to use Mississippi's as a timing tool. If you go here, what you're going to notice is when you go to the bathroom, you're only going to go to the bathroom for about 4 or 5 Mississippi's. So like 1 Mississippi, 2 Mississippi. So your length of urinating is only going to be 4 or 5. If you pee at 400 to 500 mils, you are going to hit usually 8 or above Mississippi's. Okay, so if you are let's say you go to the bathroom today, I want you guys all to count how many Mississippi's you do when you go to the bathroom. Because if you're hitting 4 or 5 and under 8, it means that you're urinating too early. What happens is your brain recognizes that and you start always urinating at this first little tiny signal and it becomes a habit. Okay? So what you need to try and do is get out of this habit. So when you get that little signal, that little tiny signal, and you realize, hey, I just went to the bathroom 2 hours ago. Typically, if I see somebody like that, we're going to do kind of different techniques to get their brain to forget about that. We count back from 10. You go sit down and you do a couple, 5 to 10 deep breaths just to try and get your brain away from that signal. Some people even have triggers. You see a bathroom, you go. Who here has triggers? Like you see a bathroom, you go. Lisa, yeah. Jen, yeah. Kara too.
I just have a question. Yeah. Why is this bad for us?
Frequency.
Yeah.
Frequency.
But why is that bad?
Because it's abnormal and it's telling your bladder to signal to your brain to go to the bathroom frequently. We're only supposed to go to the bathroom, what is it? 6 times a day, I think, depending on how much water you drink. Yeah, so it increases your urge or your frequency.
And that's bad for our pelvic health?
Oh, 100%. Yeah. It's changing the mechanics and the input to the bladder muscle. And it basically won't allow the bladder to fully fill. So then the receptors they're altered, right? If you go to the bathroom every 2 hours, that means if you go somewhere, you always have to worry about the bathroom, right? 100% bad, because it's altering the normal signal and what should be happening from between the bladder muscle and the brain. So that means as you get older, you're going to develop that habit to continue, which means when you hit your 50s and your 60s and your 70s, you're going to have to go to the bathroom every 2 hours. So the longer that progresses, the worse it's going to get.
Interesting. Somebody said that they don't even think that they hit 4 to 5 Mississippis.
Oh yeah, no, 100%. It's very, very, very common, very common. So if you don't hit those Mississippis, it's trying to find strategies to, like I said, trying to get your brain to not think about that. So you either count back from 10, or you go sit down and you do 5 deep breaths, or you try and avoid those trigger places like the bathroom. So if you can minimize how often you walk by the bathroom, right? Or some people have running water triggers. Anybody have running water triggers? They hear like the shower. Jacqueline, yeah, I used to too. So paying attention to this is very, very important with your pelvic health. Anybody have any questions about that? No? And remember what we were talking about with your pelvic floor. So I'm going to kind of describe your pelvic floor. So we have our ribs, right? And then we have our diaphragm. Our diaphragm is kind of like a dome-shaped muscle that runs across the bottom of our ribs, okay? And then we have our pelvic floor muscles, right? So this is basically, if you think of a piston, this is the top of the piston, diaphragm. Bottom of the piston is the pelvic floor. Behind your back, the little tiny muscles, that's the posterior or the back portion of the piston. And then you have little tiny muscles on the side called your transverse abdominis. These are the lateral or the outside walls of the piston. So remember when we said, when you breathe in, so when the air comes into your lungs, this diaphragm is moving downwards. So coordinating, the pelvic floor pushes downwards. So the pelvic floor has to relax to allow the air to come in and gently push down on the pelvic floor. As we exhale and we breathe out, the pelvic floor is going to come back up. So it's going to contract up. The diaphragm is going to come back up. Okay? So there's kind of like that piston where you push down and then it comes up, push down, comes up. So a lot of people, their breathing can be uncoordinated, and this is what I see a lot of in the clinic or virtually, is that they're either a chest breather. And if they're a chest breather, it changes the mechanics to how the diaphragm moves, and the diaphragm can't push down properly. Okay? Now, we're going to go over a couple of things later and kind of just assess your posture and that sort of thing, and whether or not you're, are you a chest breather? Are you a diaphragm or a belly breather? And kind of see what's going on. Okay, so that's your bladder. Today, the challenge is to see how many Mississippis you have. Like I said, normal is usually 8 or above. Okay, preferably 10.
I have another question regarding this. So 2 things is, does holding too long make it worse? Because some people can't go while they're at work.
Yes, it's like a fine line. Like I said, it's very patient dependent. It depends on what your issues are, right? If you hold for too long, it's a big challenge to your bladder. Your bladder can distend too much, that the walls can get stretched. But same thing, if you pee and it's only 10 Mississippis, that means that you're still kind of right around that 400 to 500 mils. So very, very patient specific. But if your bladder gets too full, it's also a big posterior that inferior force on the pelvic floor.
Okay, and then one more question before you move on is, somebody has the problem the other way. They don't seem to have an urge to go at all, and then suddenly they have to go and run to the bathroom so they don't pee themselves.
Yes, so that's the urge incontinence. Yes. So that's basically where you're not really sure that you have to go, and then all of a sudden you have to go, like it's literally like an instant. Like you went from not having to go at all to like you're gonna pee your pants. 100%. We see that all the time. That's urge. So sometimes with that, it has to do with pelvic floor issues, tightness in the pelvic floor, and like I said, sometimes that stretching of the bladder, that it just doesn't signal to the brain the way that it's supposed to. So there can be quite a few contributing factors to that and why that happens. So very patient specific again, having to do with the breathing techniques and everything.
Cool, thanks.
So does anybody else have any questions before we do some like kind of assessment stuff or functional stuff? Talking about peeing is a trigger for me too sometimes, Kristen. So can everybody, we're just gonna do a little test. Can everybody put a hand on their chest and then a hand on their belly for me? And I just want you to breathe, and don't think about how you're breathing. And I want you to, if anybody happens to be a breather through their chest, can they raise their hand? Haley too, yeah. Oh, Jacqueline too. Now who's a belly breather? Raise your hand. Now we're also at rest, so you have to remember during physical activity, Michelle, maybe a little bit of both. During physical activity, sometimes those mechanics change. So we're gonna do a little test. Can everybody, whoever wants to stand up and do this test, you can. So we're gonna stand up, and we're gonna do a little test called a bell test. And what it does is it basically shows you how the different positions that your body is in can affect your breathing. We talked about how breathing affects the pelvic floor, right? So anybody who wants to stand up can stand up. So if you think of your rib cage as a bell, okay? So you know when the bell, like it rings, it goes back and forth, back and forth. So this is when the bell is up. This is when the bell is down, okay? Can everybody kind of put their bell up? So stick your chest out, so you're kind of stretching through those abdominals. We tend to run like this sometimes. Can you guys take a breath in with your chest up? And then exhale. Breathe in again. And then exhale. Who breathes through their chest when the bell is up? It's very, very, very hard to breathe through your belly when your chest is up, okay? So I don't know if any of you guys notice, but a lot of us have this anterior pelvic tilt. And when you're in an anterior pelvic tilt, my chest is bell up. So that's gonna make me a chest breather, okay? Now I want you guys to put your bell down. So you're gonna kind of hunch over and take a big deep breath in. You should see your belly kind of expand. Now put your hands on your sides for me and take a big deep breath in. Is it mainly your belly breathing or your sides? Who feels mainly their belly sticking out? Yeah, Jen, Kristen, Michelle, yeah. That is also bad for you. Too much belly breathing, okay? When we take a breath in, we should get belly expansion, but we should also get this umbrella effect of our rib cage. Okay? This umbrella movement of our rib cage is making sure that the diaphragm is moving properly. So we're getting a lateral expansion and then a little bit of a breath in through your belly. So I want everybody to find a neutral bell. Okay? So not here, not here. you want to have your rib cage stacked over top of your pelvis. So not here. See that accentuated low back curve? Not here, where you got that flat back. Right in the middle. So you can see thorax stacked over top of your pelvis. Now I want you to put your hands on your sides and take a slow, deep breath in. And then exhale. Good. So take a breath in and then exhale. So what you should feel is better lateral expansion of your rib cage on the inhalation, and then on the exhalation, you should feel the rib cage come in. Raise your hand if you feel that difference. So breathe in and exhale. So stacking that bell over your pelvis is going to improve your breathing mechanics, which will help with your pelvic floor dysfunction. Okay. First thing I always do when I treat patients is we work on posture, because your breathing mechanics will not be efficient if you don't have good posture. Good mobility, good just efficiency of your diaphragm, okay? So you want to find that neutral bell posture, okay? Does anybody have, so that's kind of step one that we usually do with patients. We teach them the bell posture, and then we start working on just teaching proper breathing mechanics. And it basically will help, it will help with two types of patients. Your stress incontinence where you leak, if we have to do Kegels, we're going to incorporate the breathing with the contraction of the pelvic floor. Okay? Or if you're somebody with pelvic floor tightness or discomfort or pain with intercourse, and we determine that you have trigger points internally, we teach you how to relax your pelvic floor on that inhalation, where we're supposed to get a nice drop down of your pelvic floor to get those muscles to relax. Okay? Anybody have any questions about that?
I have a question here. It's a great question. It's a common one, is how do we get the umbrella movement of rib cage while exercising and holding our core muscles in?
That's what we're going to do next.
Yay.
Yay. Okay, so the best position to do this exercise is on the floor. Usually I'll teach my patients lying on the floor, legs propped up on the couch. You can do it in sitting. It's a little bit harder. So if anybody does want to kind of learn how to do it on the floor, feel free to lay down, or you can do it in sitting. But I'm basically going to teach you the umbrella breath and how to get the most efficient use of your diaphragm so that your pelvic floor can function properly. Okay? So if anybody wants to get on the floor, they can, or you can sit. So when we teach, I call it umbrella breathing, just because, you know, same as like opening that umbrella, right? So we want to put our hands on our lower rib cage, okay? So you're gonna put your fingers in the front part of your rib cage and your thumbs on the back of your rib cage, okay? Now, what I usually say, if you are a good breather and good breathing mechanics, you can inhale for 5 seconds. You can usually exhale for 5. If you are a chest breather, you can only inhale for 2 to 3 seconds because the air isn't getting all the way down into your lungs and you have a shallower breath. Okay? So you're gonna put your hands on the front. Now, before you breathe in, you are going to put an inward force onto your rib cage so that when you breathe in, you really feel that lateral expansion of that umbrella. And it's just a little visual tool to make sure that that air is going all the way down into your lungs and the diaphragm is pushing down, okay? So hands in the front, and you're gonna kind of push in. We're gonna inhale through our nose we're gonna try to do 5 seconds, okay? So you're gonna breathe in. And then you're gonna exhale and make an S sound. So, on that exhale, you know, when you breathe out and you get that, that is the contraction of your abdominals. That is good for bracing when you're doing physical activity. That's the bracing feeling. You don't want to do that bracing feeling of pulling your belly button in, because if you pull your belly button in and hold it, can you even breathe? Like I can't breathe like that. So we teach people that contracting your abdominals is actually on that exhalation to get that bracing mechanism, because you can feel everything coming together when you do that. Okay, so let's try a couple of them. So hands on your sides again. You're gonna breathe in nice and slow through your nose. And exhale. Breathe in. And breathe out. Who still has trouble getting that lateral movement like the umbrella? Can you raise your hand? Good, and exhale. Good, one more. And exhale. So if you suffer from a diastasis as well, where that separation of the abdominals, as you exhale and you get that rib cage to come back in, that's pulling those abdominal walls together again. Okay, so if you have that abdominal separation where the rib cage separates, that breathing out and that exhale where you start to feel those rib cages come in, that's that bracing technique that's going to pull those abdominals back together. So that's basically what we call umbrella breathing. So the first two things that I teach people is the proper, stacking your bell over your pelvis and proper diaphragmatic umbrella breathing.
Okay, two questions for that. Is it not possible to support your core while inhaling and doing abdominal work?
When you inhale, sorry, which question was it?
I think the answer is it is possible, but the question is it not possible to hold your breath or hold your core while inhaling and doing abdominal work?
Oh yes, 100%, but it's more pressure on your pelvic floor.
Yeah. What I always say when I'm instructing is, because I hate the whole pull your belly button thing in. I don't subscribe to that. So I always tell people while I'm instructing, which can give you kind of like a visual, is that pretend you're a boxer and I'm going to punch you in the gut. You don't hold your breath. You just brace and you keep breathing. And it's like, I'm going to keep punching you in the gut and you're going to keep breathing and you're going to keep pushing back. So that's how you can do both at the same time. Do not do the whole pull your belly button thing in.
No, it's just changing the dynamics of everything. We used to think that was how you kind of, how you brace yourself, but it's not. But if you do that exhale and you, at the end of your exhale, if you really think about what you feel in your abdominals, it's exact same thing like Ashley said, like just pretend you're a boxer and you are bracing yourself for a hit and you just want to contract those abdominals. It's not pulling the belly button through to your back. No. It's just about that full contraction of your entire abdominal wall and bracing and pulling in those rib cage to close those abdominals closer together.
And the other question is, when you exhale and engage your core, should you also be pulling your pelvic floor up like a Kegel? But that you said is very individual.
Exactly. So like I said before, with those breathing techniques that we just did, we start on the floor because it's a little bit easier and there's no gravity that's involved. So somebody who's having pain with intercourse or they're having urge issues and we find out, hey, they have some trigger points, we would work on more so that inhale, trying to get them to visualize, okay, the pelvic floor, as you breathe in, that pelvic floor is relaxing. Somebody with trigger points is not going to do a Kegel. If you have a stress incontinence and we realize, hey, she has a really weak pelvic floor, then we're going to incorporate that Kegel and that drawing up and trying to close that pubovaginalis muscle so that it closes off the urethra so that they don't have any leakage. But when it comes to that stress incontinence and that contraction of the Kegel, what I always tell people is we have two types of muscles, and Ash will second this. you have your fast twitch muscles, you have your slow twitch muscles, okay? So even the pelvic floor has those, and people say, well, what the heck is a slow twitch and a fast twitch muscle? Fast twitch muscles are the muscles that contract really fast, okay? So, and slow twitch are more your endurance muscles that need to go for a really, really long time. So if you cough or sneeze, what do you think you need? Your slow twitch muscles to turn on or your fast twitch muscles? Fast twitch, yeah. So when we do Kegels, we teach two things. Activation of the fast twitch, right? How many can you do in 10 seconds? Most people can only do 4. How many should you be able to do? Probably around 8 or 9 in 10 seconds. And then we also teach endurance muscles. So that's like when you want to start working out with Ash and you're having some issues with the stress incontinence and you want to be able to do lunges or you want to be able to go for a run. It's the endurance muscles of the pelvic floor that need to contract and hold for longer periods of time if you're running for 10, 15, 20 minutes. So if you have issues with like coughing, sneezing, all those fast movements, we teach a little technique called the knack. Why we call it the knack, I don't know. So what it's basically doing is it's teaching those fast muscles to turn on fast. So who here has the issues with coughing and sneezing? Yeah? So if you were my patient and I said, okay, you know what, I think you actually do have some pelvic floor weakness, those fast twitch fibers have to be activated a little bit better. All I get you to do, if you feel a cough or a sneeze come on, you pull that raisin and you try to stop that urine flow, you cough, and then you squeeze 3 times. 1, 2, 3. That's the knack. Okay? So you're gonna sneeze. I feel sneeze coming on. I'm gonna draw in that raisin, tighten that pelvic floor, stop my urine flow or visualize that. And then I'm gonna go 1, 2, 3. You do that, it becomes a habit. And sometimes that's all you need to stop the coughing and the sneezing is just initiating the knack. But same thing, it's very patient dependent. If somebody has trigger points, painful or tightness, everybody's very different.
I have a good question. That's an interesting one. Is can scar tissue be considered a trigger point?
Oh, 100%. Yeah. So after I had Arya, my first baby, do you remember how I said I had pain with intercourse? So I think I ended up having 3 areas that had to be stitched. So I had to see a therapist who taught me how to do basically soft tissue massage to my scars. And I had 2 muscles that had trigger points. So I had to learn how to do trigger point release to those muscles. And as soon as I started doing that, it was like night and day. I had 2 sessions and then there was less pain with intercourse.
That's amazing. We only have about 10 more minutes. Is there anything else that you wanted to cover to kind of wrap it up, or should we start going over some questions?
I'd go over questions, and then if anybody doesn't have any questions after this call, or you want to kind of like brainstorm your specific case, like I said, because this is so generalized and there's so many pelvic floor issues. Because even down the road, Ash, we could just do, a session on one specific thing or one other specific thing. Because it's an umbrella.
I was actually thinking that. So I have some questions that were even sent to me, and I just want to say to you guys, I got all the questions, but I'm only going to ask the ones that are specifically relevant to this, what we've talked about today. But we could break it down into even like pre or postnatal. We could break it down to a specific pain or whatever that you feel. So I want you guys to know that it's not that I didn't get your messages or questions. I just want to make sure that we kind of keep it on par with what we've talked about today. So not that they're not relevant, I shouldn't say that, but like they might be completely separate problem. Okay, so let's stick with the Kegels for a little bit. One is, does pain in the tailbone while doing Kegels signify anything?
It could be anything. So when I assess patients, whether it's in the clinic or on our virtual platform, when we do virtual platform, I teach the patient how to assess themselves, obviously. But we always take a look at hip and pelvic mobility, because if you don't have normal hip and pelvic mobility, like we were talking about, like your rib cage, things can't move properly. So you could have coccyx, which is basically your tailbone. You could have issues with your tailbone mobility, basically how that little bone moves. You could have tightness in the muscles that attach to the tailbone. So you can see these bigger muscles here, iliococcygeus, obturator internus, all these muscles attached to the back of the tailbone. So if there's tightness there, it can affect how your pelvis and how all the Kegel muscles work. So sometimes basic pelvic stretches will reduce that.
Wow, that's awesome.
Now I did see Amanda had asked a question about like trouble feeling yourself do Kegels. On our virtual platform, when I do teach people to assess whether or not they can do Kegels, we just use a mirror. So if you're doing an actual pelvic floor contraction and pulling that raisin in or stopping, you're gonna see your perineal area, so the area between your vaginal hole and your rectal hole, you're gonna see it lift up. You're gonna see your clitoris lift up a little bit, and you're gonna see your anus do like a little anal wink. So you can actually use a mirror and assess yourself if you're doing it. It's cool, I love it.
It is. Do you do internal exams at your clinic?
I do, yeah.
Awesome.
So usually the first visit, I'm looking at posture, I'm looking at breathing mechanics, I'm looking at pelvic mobility. So, and it also always depends on the comfort of the patient. I find a lot of patients are super comfortable with me because I've experienced all ends of the spectrum, from pelvic pain to a pelvic organ prolapse where, you know, some days I'm in tears. So we usually, the first visit, we work on mechanics, pelvic stretching, things like that. And then if patients are comfortable doing the internal exam, then we go from there. I always say assessing the pelvic floor without an internal exam is like an ortho surgeon or a physio like doing a knee exam through like a knee brace and jeans, right? Mm-hmm. But to somebody like me who does it like multiple times a day, like every day, it's just like I'm basically like an OB.
Yeah. Right? Here's another question is, if you hate doing Kegels because of sensation, does that mean that you're doing them wrong?
Not necessarily. I think it depends. Some people, when they do Kegels, it's actually you can actually get turned on a little bit because you're getting activation of your clitoris. Yeah, me too. Big time.
I get really turned on. I should not be doing it in the car.
I do too. So you're not alone in that. But sometimes, let's say you have sensitivity of the pelvic area, like we were talking about the skin, like of the vulva or the vestibule, which is tissue. If you Google it, you can have irritation of that skin. So sometimes just doing pelvic stuff or Kegels can irritate that.
When does it get to the point where you actually have to get surgery to correct a bladder issue?
So over in Europe, which is very surprising, it's not surprising, it's good, and I wish we would go in this direction. You have to have physiotherapy before they ever will consider any surgical intervention for any pelvic issue. Specifically, usually when you have surgery, usually it's related to a prolapse, so either a bladder prolapse dropping down, your uterus dropping down, or your rectum dropping down into the vaginal area. And I'd say like 90% of postpartum individuals in Europe will actually, their OB sends them to a PT right away, no questions. So if you have physio for a prolapse, like me, studies have shown prolapses are graded. I'm not sure if any of you guys have heaviness in the vaginal area or just like feel a pressure. Or if you have like a rectal prolapse, sometimes you'll feel a tense ball. But usually with physio, there's different grades to the prolapse. So depending on how, is it right at the entrance of the vaginal hole? Is it at the entrance of the vaginal hole? Is it past the entrance? Physio has been shown to reduce the prolapse by usually 1 grade. And getting constipation under control for prolapses is very, very important. And constipation is a whole other topic, and it has a huge influence on pelvic floor issues. I don't know who here, I know it's a touchy subject, but who here has pelvic floor issues and also constipation issues? Yeah, so that's that is a whole other ball game and a huge influence on pelvic floor stuff.
I have time for 2 more questions and then I have to go. So I know there were so many questions, Julie. These are really good. Some of them were really specific.
Out after that's great.
Okay, amazing. Because I was going to say some of them were really specific to pre and postnatal, which obviously this all impacts, but because they're a little bit more specific, they could either reach out to you for a consult. You are taking new patients right now, right? So, which was one of the questions. Okay, but let's just stick, because we're kind of on this topic with the pelvic floor, and then we'll wrap it up. And if anybody has questions, that they can contact Julie, and then maybe we'll do another one. So I'm sorry if we didn't get to your question. Are pelvic weights actually helpful? She's heard mixed reviews.
Yeah. So pelvic weights can be helpful if you have a weakness in your pelvic floor. The key is using them on a proper dosage, if that makes sense, and making sure that you're not using a weight that's too heavy. Usually in the clinic, if I do have to prescribe pelvic weights, we do EMS, which is like electrical stimulation, to try and help the pelvic floor if you're really weak and you have a really hard time feeling that connection. It's basically kind of like a little tiny dilator that sends like little twitchy feelings to your pelvic floor. But pelvic weights can be useful, but very patient specific again. If I can avoid using them, then I will. I would rather be a little bit more functional, but I have prescribed them in the past and they can be very useful. Usually the company that I'll recommend is Intimate Rose. They have an amazing pelvic wand that can be great for trigger points. And then they also have different variable pelvic weights, and they're usually made of a really nice silicone. So they're comfortable to use as well.
Awesome. And would you suggest stopping peeing while urinating to get the feeling of a Kegel?
No.
This is a big misconception.
100%. And you agree with me on that?
Oh yeah.
Yeah. If people are like, I don't even know what to do, I'll say, like, you know what, do it once when you're urinating, try once, just get that sensation. But no, when you need to go to the bathroom, you need to go to the bathroom, and you need to let that detrusor muscle that surrounds the bladder wall to do its thing.
I heard a really good, when I did pelvic floor therapy while I was pregnant, because I used to stop peeing and then starting again because I thought it was good, and then I learned otherwise, and I'm like, oh my God, all those years, not good. But the way they described it is, imagine you have a tampon in and it's falling out and you got to pull it back in without touching it. Yeah. Right? So it's like literally get that sensation where you're like out in public, your tampon's falling out, you're like, pull it back in and like kind of get that like drawing in feeling. And then I had to do reverse Kegels, which is why I think it's really important people see a physiotherapist if they have any problems, because I was leaking pee and thought it's because I had a weak pelvic floor. So I was going crazy doing all these Kegels and making it worse.
Yes. So in your case, that's why I said it's very patient specific. In your case, your pelvic floor muscles were already so tight that the canal, that vaginal canal, the urethral canal couldn't fully close because you were so contracted. And when you needed it to fully contract, it was already so tight, it couldn't contract anymore.
Yeah.
Yes.
Exactly. So I think it's really important that people do it specific, because you can go online and read all your things, which I was doing. And I even took pre and postnatal specialists, and I'm like, oh, I know what I'm doing. And I made it worse. So it's really important. Just because you leak pee doesn't mean that you have a weak pelvic floor.
Yeah,
it could actually be too tight.
And honestly, my biggest factor in reducing my prolapse, I worked on Kegels, and I worked on Kegels like over and over and over the past like year or two. And until I started looking at my breathing mechanics and the fact that I was a chest breather and I was increasing that pressure in my pelvic floor region by being a chest breather, as soon as I started doing that, my prolapse symptoms decreased. As soon as I got my constipation under control, or trying to, because you know how much I'm not good at drinking water. As soon as I get that under control, my prolapse symptoms decrease significantly.
Amazing. That's really good. Well, I have to go, guys, so I'm so sorry. I have a class, and I know we could probably sit here and pick Julie's brain forever, but I want you to know that we've recorded this. We're going to send it out, and I'm also going to send you Julie's information. So if you guys want to get in contact with her, she is doing virtual consultations, like she's mentioned, which my husband's been doing with her, and it's been really good. So if you guys want to learn a little bit more, make sure you guys connect with her. And thank you so much for coming on and hanging out with us at 8 a.m. on a Saturday.
Yeah, thanks guys. Like I said, it's such an umbrella term. There's so much to cover. So that's just the basics of what we see a lot in the clinic and things that can help. So reach out to me either Facebook on our Facebook page, Instagram at fun_physio, or you can email us or check out our website, fundamentalsphysio.ca.
Awesome. Thank you so much, Julie. I appreciate it.
Anytime, guys.
You rock. Okay, goodbye, everyone. Have an awesome day.
Class.
Thank you.